Welcome to this pre-lunch session on impaired hearing by Ms. Selvi. And I think before the introduction is nicely split on the screen, and before I don't want to waste any time, I turn, Madam, the mic is yours.
Yes, please. Can I start? I would like to thank the organizer for giving me these opportunities. I know it's pre-lunch session. I'll make it as interesting as possible. I would like to change the slide. Okay, thank you. So I'm going to talk about pediatric hearing loss, assessment, screening, management. So myself, Muthu Selvi, working as assistant professor in Sri Ramchandra Faculty of Audiology, Speech Language Pathology. So the content of my presentation is the need for early identification. Then we'll move on to how to identify kids with hearing loss, especially here at today's talks. I'm going to focus mainly on children. And what is the outcomes with a hearing aid user and cochlear implant user? So why we need to identify the children with hearing loss early? So not only identifying the children with hearing loss early, what is more important is rehabilitation. So the two key points I would like to stress over here is, all of us knows there is something called neuroplasticity. This so your central nervous system get altered by any insult to the sensory system, like your hearing loss. And again, if you give a training, so we can do a modification in the central auditory nervous system. So if there is any insult, suppose to say if the child have hearing loss, so there is alteration happening in the central nervous system. And again, this can be reversed. The key is this can be reversed with the help of proper amplification or the auditory stimulation with cochlear implantation, and the reverse is possible. Okay, but again, this we need to do it early. If you give a stimulation when the child is beyond your critical age, for children we say with respect to auditory stimulation, the critical age is less than 3 years. So if you give a stimulation less than 3 years, beyond critical age, it is very difficult to reverse the central auditory nervous system structure. And there is something called cross modulation reorganization happens. So what does that is? You'd have seen the child with hearing loss, they tend to look at your face. What they do? Lip read. So why is that happening? Because the child does not receive auditory stimulation. So there is a space allocated in your brain for auditory system, that is in the auditory cortex. Suppose if you don't give the stimulation, what do the child tend to do is, they look at your face, facial like face gestures, and they look at your face for lip reading. So what is happening in the brain is, so this auditory brain, the place which is allocated for auditory system is it's getting borrowed by the visual system. So if it is getting borrowed, what happens is the space which is allocated for auditory system is reduced. So when it's actually reduced, even like if you give a stimulation or rehabilitation, the space allocated itself is reduced. So it's very difficult to use the restricted area in your brain. So this is what will happen when you implant the children late. So this is one of the important studies. All of you know that the Tamil Nadu government provides free cochlear implant for children less than 6 years. Why the government decided to give an implant for less than 6 years? This is based on this one of the important studies where they looked at cortical maturation after cochlear implantation. So you give auditory stimulation for congenitally hearing impaired children. So you look at your cortical maturation. So in your cortical maturation, you can see here. So this is your P1 peak. No, it's not clear here. So you start getting the P1 peaks the moment you introduce the auditory stimulation to the brain, and you start getting it as early as 3 months after the implantation. So slowly the latency of P1 peaks start to reduce, and one point of time it reaches with the normal limits. So in the graph you can see that the line graph shows the normative range of P1 latency. Our aim is to bring back this latency to the normal range. So the red line shows the children who are implanted less than 3.5 years. So you could see that the P1 latency is reaching to the normal level after some point of the time. And the blue one for the children who are getting implanted between 3.5 years to 6.5 years. You could see that the 50% of children's the P1 latency is they're getting into the normal level, but 50% of them we are lost. So they're not able to reach the normal level. And if you implant the child more than 7 years, they're never able to reach to the normal. The main key point what you need to understand is, if you implant the children, or if you give a auditory stimulation either with a hearing aid or cochlear implant less than 3.5 years, we can make this child like a normal hearing child. And if you implant the children between 3.5 years to 6 years, there are some children with proper family support, we are able to get them to the normal level, but they need the proper support throughout their educational system. All of you know that it's so hard, to teach the child, normal child itself with the education system, and we see that they require the support from the teacher, special educator, and the parents throughout their lifetime. So as we know that it's important, the last two slides is trying to tell us the early identification, early rehabilitation is the key. So how do you go about it? So first is you start with neonatal hearing screening to identify the children with hearing loss early, and we look at the prevalence rate, that's the incidence rate. So this is a Nagapurnam et al. Study which is done in India. In general population per 1,000 birth, we can see that in the regular not at risk general babies, we can have 5 babies with the hearing loss, and at risk babies it is almost 10 in 1,000 live birth, and not at risk it's 4 among 1,000 birth. So we know that we need to screen almost 1,000 babies to identify 5 child with hearing loss. So here the time is very crucial for us. So here we need to have some automated system. Yeah, you can play the video. This is called OAE screener. So as we know that we have got very less time because we need to screen almost 1,000 babies. So we have, this is automated system which can be done by any technician or nurses. So which will give us the child is at risk for hearing loss, not at risk for hearing loss. The key is, can I have the video played? Just PR screener, we check up to auditory now. So the previous OE screener we check up to inner ear. This 2 screener just takes hardly a minute to the child is cooperative, will be able to finish the testing within a minute. So with that we know the child is able to hear well, and the good thing about both the screening is we can identify the children even with minimal to mild hearing loss. Community-based material available which can be done to the community level. This is done by Vidya Ram Kumar. This is one of the community-based project. We can do it by any other technician where we have a different material which is age-appropriate material which can be used for screening hearing and speech and language. Next slide. So this is for screening. So once you are done with the screening, this is the NHS protocol what we follow in Sri Ramachandra Medical Center. So initially we look at the child's high risk factors and we do OEE and as well as ABR. We do OEE not at risk children, ABR at risk children. If they pass, we'll give them, tell them about normal auditory development, and we follow them at 8 months with the behavioral screening, provided the child have HRR. And the child, if it is a refer, will be done in the ward. And if it is refer, we'll again redo the testing at the OP procedure after a week or 2 weeks. And if the child is a pass, then again we follow them at 8 months. If the child is refer, then immediately provided on the same day or very next day or within 3 days, we'll do the diagnostic testing, especially first one with the ABR, diagnostic ABR. If you are able to get normal ABR, again we follow them at 8 months. If you are getting ABR, some abnormal reports, there is some, if you are not able to get response up to the lower level, and what we do is we'll do the other behavioral testing. So if the other behavioral testing is telling you, say the child is responding well, and again we call them again after a month, and again if you are not getting any behavioral response from the child, and the ABR response also we are not adequate, we immediately start with a hearing aid, and follow them over like 6-9 months. And in that time, if the child is severe to profound hearing loss, we tell them to go for cochlear implantation as early as possible, before at least 9 months to 1 year. So this is our diagnostic assessment, what we follow. The first one is behavioral observation audiometry, visual reinforcement audiometry between, this is age appropriate between 6 months to 3 years. Then again condition play audiometry. Since like all of you are pediatrician who look at the children and day-to-day life, I would like to just give you some brief about how do you look at the child's behavioral response. I need to look at get the videos right, please. So here, yeah, thank you. So here the newborn child, this is a child who are just 2 days old, and any newborn child, what we look as only the involuntary response. So we generally look for 2 involuntary response. One is, I don't know, can you just, brother, can you play that also? So 2 involuntary response, one is the startled response or a palpebral response. So startled response is when there is a loud sound. Again, the other thing what you need to realize, the child will respond only to the sudden loud sound. There will be overall movement, body movement, that is your startled response. Any the drum kind of sound, the child will clench the eyes. Like that is the startled response what you could see. The next response what you see is oropalpebral response, that is for the drum.
Okay.
So can you just see that child's eyeball movement?
Okay.
So when the child is newborn, you look for only involuntary response. The next. So this is the normal child who was just 6 months old. The moment child has a neck control, so the child starts searching for the sound. So you can play the video. So this is the response what you look for. 4 months old baby, when the child starts looking at the sound. So this is for the 11 months baby. Again, you look for the localization response, that is a head turn response. What is the difference things what you find here is the sudden response. The previous baby, we took some more time to look at the source of the sound. If it's older kids, generally they do it a little bit earlier. Just play the video. So just look at the sudden response. This is the what we say is a time lock response. What you need to see it, the children beyond 6 months of age. Next video. So this is 13 months. You can play the video. This is actually, this is not a proper response. I would like to show. Whenever you look for the child's response, the child has to be quiet. So here the child is not quiet. Just to know that how do you look at the response, always ensure that the child is quiet before presenting any stimulus. So this is 18 months old baby, where the child start localizing from above itself. Like the child start to localize all 4 directions. So you can see the child is quiet before presenting the stimulus. And this is how you look for behavioral response. And again, don't present again and again. This is the parents who are doing it. And because if you present it again and again, leads to habituation. All of us know how do we respond to name call of our parents. The same way. So don't make the child habituated, presenting the same sound again and again. So this is for the normal child. How do you look at the response? And the same setting we are trying to create in the audiometric setup. So this is the head turn response. So the response is reinforced by any material, lighting material. So with this we can also check the minimum level the child is responding to. The next one is, this is for children who are 6 months to 3 years. This is for older children who are more than 3 years. You can play the video. Play video. So we just do it as a play activity. When there is a sound, the child has to drop the blocks. So slowly we'll reduce the sound and look at the minimum level the child is responding to. So this is something that you can also tell the parents to look at it at home. And other than that, we have AAR, auditory brainstem response, autoacoustic emission, to know whether the child is having hearing loss or not. If yes, how much is the degree of hearing loss? So this are thing what generally we know. And when you get audiogram from the audiologist, what you need to really interpolate from your background is look at your familiar sound audiogram. So if you look at this picture, we know the frequencies and the intensities here. And the middle, whatever we have something called speech banana, and where most of your speech sounds lies. That is between 30 dB to 60 dB. So when you look at here, and so this is what your most of the speech frequencies lies. So definitely the child has to hear between 30 dB to 60 dB to listen to all the speech sound to develop normal speech and language. Okay. So if that's supposed to say this child, if you get an audiogram at 70 dB, that means the child is hearing only at 70 dB. So definitely the child is not getting any speech sound. And definitely, but the child will listen to some dog barking, and if the mother is cooking, if it is making chutneys and other thing, the child will listen to the grinder, the mixie sound and other thing. If it is mobile phone, the child will listen to. So though you tell the parents that the child has loss, they may not agree because they know the child is responding to all the sound. But that is not enough. You need to look at this sound. So since the child is not listening to speech sound, is not going to develop the language, you need to start with you need to give the stimulation first and start the rehabilitation. Next slide. I'm crossing time. I just finished. So then I'll skip the video next. So this is previous slide. Okay, so this is the like the child with 30 dB loss. So we know that 30 dB loss is less, but still the child is not going to listen to some of the speech sound like shh, all this sound. So child will not be able to differentiate singular versus plural, like boy, boys, and stop. The pa sound is going to be very soft. The child is not going to listen. So child generally will have misarticulation. So irrespective of whatever is the degree of hearing loss, you need to start giving the stimulation with appropriate stimulation. Next slide, I'll go quickly. So what do we decide? Do we give a hearing aid or cochlear implantation? This is as per the FDA criteria. If you have a loss, the white area, the hearing aid is more than sufficient. And the child has got loss between 70 dB and above, you need to provide cochlear implantation for the child to listen to, hear the sound. So, no, previous slides, please. So we know that most of the parents are really worried about hearing aid and cochlear implantation because of cosmetic reason. We do have a hearing aid, like the receiver in the canal hearing aid, we can see the hearing aid is lies here. So we do have a better technology now, smaller technology, so that the parents, like you don't tend to feel that the child is wearing. So this is the cochlear implantation speech processor, what you see, that is half the ear model. So it can be easily hidden with the hair. So now the cosmetic is something that the technology, with the improved in technology, we are able to overcome to some extent. So the issue is, so we know that we, as an audiologist, we are able to identify the children with improvement in the technology and NHS program. What we fail is the follow-up. So even in some of the NHS neonatal hearing screening kits, we lose them in between. Even when we identify the children by 2 months, and again it's very difficult to make them understand to wear the hearing aid and get them ready for cochlear implantation. Mainly because, especially in premature babies, they think that the motor development is delayed, so auditory development is also will be delayed. So that is our assumption. So that is the main issues. Another thing is the partial hearing. So the partial hearing, generally the parents takes lot of time to accept the child as hearing loss and to go with hearing aid. And then again, the cosmetic reason, where we know the technology, it's better, but still parents are really worried about their child wearing cochlear implant or hearing aid. Just give me 2 minutes. Next slide. So the factors affecting outcomes, what we say is here I'm going to focus only on age of implantation. And next slide. So this is the child. If you can play the video. So this is the day 1 of your switch on. So when we either you make the child to wear the hearing aid or cochlear implant, we generally tell the parents saying that thing that is the first day how the child will normal child will respond. So now we saw if it is a first day, the day we are going to wear the speech processor or hearing aid, the child will respond only to the loud sound. Generally they look at only involuntary response. The child has to undergo training to develop normal speech. And this is a child who we implanted at the age of 1 year, and you can see the response immediately after 6 months. Okay, fine. So this is a child, if you, that is to say, if you implant the child early, you can get to them to the normal level as early as possible. And if you could not able to take, at least take from this child, this child, we know that we saw them by 3 months, we were able to identify the child having hearing loss. And so this is 3 days after the child wearing the hearing aid, and the child was not responding, but not to the softest level. So what we generally look for, that the child has to respond to the conversational level. So we followed up this child, and by 9 months we told the parents that it's the time that you need to go for cochlear implantation because the child has severe hearing loss. But when you look at the same child by 3 years, because the parents were not ready to go for cochlear implant, as they really worried about surgery. So
who's watching the Ganda? Say the sentence. Super. Who said pandas have a sharp sense of smell? With what?
Just I don't know whether you are able to appreciate this child's voice and the previous child's voice. Just generally what we realized that what is more important is not to identify the child with the hearing loss early, to rehabilitate them early. So the previous child we could identify and start giving cochlear implantation by 1 year, and the child with the family support we could get to the normal level at least by 6 to 12 months. And this child, we identify the child having hearing loss by 4 months. But again, we followed up this child, and just because the parents are apprehensive about the surgery, and the child was fitted with the hearing aid continuously. Still, the child is on with the hearing aid. And we know that if you look at the child's output, it is not normal. We could appreciate the child has typical hearing impaired voice. And so that's what is my take-home message is lastly. So, lastly. So what is more important is if you want the child to speak normally, you need to have all four pieces fixed. One is to identify the child having hearing loss and fit them with appropriate management. So though it can be medical, it could be hearing aid, or it could be cochlear implant, you need to make the decision. But what is more important is the parent has to accept that and start the rehabilitation. And what we feel is more important is the family support. So the parents has to, the family support is important. Whether you wear the hearing aid or cochlear implant, the parents has to be coming for therapy minimum of 1 to 2 years. So for that we need a family support. So if you have 4 pieces fixed, so definitely we can have all the child with hearing loss into normal child. Thank you.
A very well presented presentation. It was really very useful. The audio visuals were very excellent, madam, and you are given a full global outlay of what should be done, early identification, and what should be done, and what's the training, because we all know cochlear implant is not a simple one step. It also improves a lot of training and parental support, and we really appreciated all your early advocate slides and everything. So once again, thank you so much for having done this pre-lunch session. So any questions you can ask madam during the lunch, and we'll have a 20-minute break. So as per the organizer's suggestion, and we expect everyone to be back by 2:22 here. Thank you so much. We'll break for lunch now.
Thank you, sir, for being the chairperson for this session. And it's not a suggestion from the organizing committee. It's our humble and kind request from the organization committee to please join us again at 2:20 for another brainstorming session on pediatric epilepsy. Thank you.